Good evening, everyone, and welcome to this installment of RCDSO Connect. I'm Andrea Foti. I'm the RCDSO Deputy Registrar and Privacy Officer, and we're really thrilled to have you with us today. This RCDSO Connect session is going to focus on an overview of two of our newest standards. One standard is on professional boundaries, and the second on consent to treatment. We're really pleased tonight to have with us two RCDSO Council members, Dr. Antony Liscio and Dr. Deborah Wilson. And they will be our presenters. They're going to take you through the standards of practice and really delve into the rationale behind the requirements in the standard and some practical guidance to effectively integrate these standards into your dental practice. That's what we're after. Tonight, for engagement with you and asking questions, we do have a Q&A feature that we're going to ask you to use. You can find that at the bottom of your Zoom screen. And please feel free to go ahead and submit questions throughout the presentation. We've got a great team of college staff on hand, and we're going to get to and answer as many questions as we can. In a moment, I'm going to introduce our two presenters, but before I do that, I want to start, as we always do, with a land acknowledgement. Although we're all located virtually in different areas of the province, our land acknowledgement is going to focus on the lands on which the RCDSO offices sit. So the RCDSO offices, they are on the traditional lands of a number of Indigenous peoples, the Mississaugas of the Credit, the Anishinaabe, the Haudenosaunee, and the Huron-Wendat peoples. And these lands, we're just at Rosedale subway station for anyone who's familiar. These lands are known to some as Toronto. Toronto is covered by Treaty 13 with the Mississaugas of the Credit. And we know it's home to many diverse Indigenous communities, First Nations, Inuit, and Métis people. The land is also part of the Dish with One Spoon territory, and that's a treaty between allied nations, the goal being to peaceably share and care for the land. At the RCDSO, we really accept our responsibility to each other and this land, and the idea and goal to live and work in a spirit of peace, friendship, and respect. We're committed to actively supporting the necessary work toward truth, reconciliation, and equity. And particularly as a regulator, we embrace our role in regulating dentists, protecting the public interest, and strengthening our partnerships with Indigenous communities to advance access to safe and equitable oral health care. Okay, thank you. Now, it's my pleasure to turn to our two presenters. We're really fortunate to have with us two dentists who also happen to be members of our council, our board of directors. First, we'll have Dr. Antony Liscio as a speaker. And Dr. Liscio is a co-chair of our standards working group. And that's a group that provided direct input into both of the documents you'll hear about tonight. And Dr. Liscio is a council member in District 9. He's had over 5 decades in dentistry. And Dr. Liscio is deeply committed to strengthening public protection and ensuring public safety through regulation. Our second speaker tonight is Dr. Deborah Wilson. Dr. Wilson is also a co-chair of our standards working group, and she is a council member in District 10. Dr. Wilson is a proud 1984 graduate from the University of Toronto Dentistry Program. She currently practices general dentistry as a solo practitioner in Toronto. Dr. Wilson is also an avid tennis enthusiast. She enjoys listening to music, painting, and spending time with her family and friends. And I really want to thank both Antony and Deborah for taking the time to be with us tonight and to lead you through the two resources that we'll cover. So with that, Antony, I'm going to turn it over to you, please.
Thank you, Andrea, and good evening, everyone. As Andrea said, my name is Dr. Antony Liscio, and as you've heard, I'm going to provide you with an introduction to the RCDSO's new standard of practice, consent to treatment. Now, before discussing the standard itself, I want to take a few minutes to remind you of the fundamentals of consent. We've all heard the word, but I think it benefits to delve a little bit deeper. So where does the duty to obtain consent actually come from? Why is it such a critical component of dental professionalism? And how can we avoid the common pitfalls and challenges associated with it? The rules and requirements governing consent to treatment arise from overlapping areas of ethics, law, and professional regulation. The most fundamental principle is that treatment cannot be provided without the full and informed consent of the patient. Now, in some cases, consent can be obtained by someone acting on behalf of the patient, or in some cases, treatment can be provided without consent. But these are exceptions to the basic expectation that the patient consent is fundamental. You'll also note from the definition on the screen that treatment is defined very broadly. In other words, virtually anything a dentist would offer their patient in the form of treatment or care would meet this definition and require the patient's consent. At its core, the requirement to obtain patient consent to treatment reflects the moral and legal right of every person to make decisions regarding what treatment they will or will not accept. Now, this is a reflection of every patient's right to bodily autonomy. Consent also constitutes the legal authorization for treatment, and it can help dentists avoid negative consequences. What are some of these consequences? Could be legal action or complaints to the college from the public. The failure to obtain consent prior to administering treatment may leave a dentist open to allegations of battery, negligence, or professional misconduct. And I'm sure none of us want that. Now, there's a robust legal framework which sets out the requirements for consent. This includes both common law and statute. In statute, consent in Ontario is governed by the Health Care Consent Act, which sets out legal framework to obtain consent for treatment. It applies to all regulated health professions, not just our own profession. The law sets out specific requirements that must be satisfied for patients to express their autonomy and make treatment decisions. As you'll see when we talk about the RCDSO standard, it largely reflects the requirements that are set out in this legislation. Importantly, as I mentioned, it is also an act of professional misconduct under the Dentistry Act for a dentist to fail to obtain consent to treatment in circumstances where consent is required. And believe me, consent is required in most every situation in one way or another. Looking at college complaints and investigations, issues around consent, including a failure to obtain informed consent, are among the top 5 most frequent issues that come up. This brings us to the RCDSO's guidance for consent. Our new standard of practice, consent to treatment, was approved by the RCDSO Council this year on March 27th. This standard was developed following the college's usual standards review and development process, which included public consultation, engagement with subject matter experts. If you're interested in learning more and about the information about the process, it can be found on the RCDSO website. The new standard updates the college's guidelines for dentists and replaces the former practice advisory, which was approved back in 2007. The new standard of practice is also accompanied by several supplementary resources which help clarify dentist obligations. These include a new frequently asked questions and infographic, all of which are available on the RCDSO website. So in terms of what's new or what's changed, between the former practice advisory and the current standard of practice, the fundamental requirements for dentists with respect to obtaining consent to treatment have really not changed. I think that's the critical message. Overall, the revised standard has been reformatted for clarity and accuracy, and the content has been updated and expanded throughout. The next slide sets out the key content addressed in the new standard. It significantly expands on the content that was previously addressed in the former practice advisory. The new standard now, excuse me, the new standard now comprehensively captures all dentist duties and obligations, including those set out in law. As noted, a number of supplementary resources have been developed to support the release of the standard. These include a new consent to treatment infographic, which can act as a kind of chair-side reference. We have developed a series of FAQs on key topics. These include, as examples, assisting dentists in understanding the requirements for communicating material risks as part of the consent discussion, providing care to minors with divorced and/or separated parents, delegating the consent discussion, and using creative consent forms. Now that we've covered the basics of the new standard, I'd like to remind you of the fundamental elements of consent. This consent is the content is all captured fully in the new standard. As noted, in order to proceed with the treatment, the consent that is obtained must fulfill the conditions set out in legislations as well as the standard itself. First, the person providing the consent must be capable with respect to the treatment being proposed, and without capacity, there can be no consent. I repeat, without capacity, there can be no consent. Secondly, 4 criteria must be satisfied in order for a capable person to provide valid consent. The consent must relate to the treatment being proposed. The consent must be informed. The consent must be given voluntarily, meaning that the consent is not given under duress or coercion. And finally, the consent must not have been obtained through misrepresentation or fraud. Importantly, consent cannot be obtained retroactively, meaning it cannot be obtained after the treatment has been provided. Makes sense. As mentioned in the previous slide, consent must be informed. The informed piece is by far the most challenging and nuanced element of consent in practice. So we're going to focus a little bit of extra time and pay attention on this particular matter. Before giving consent, the Healthcare Consent Act requires that a person provided with the information that a reasonable person in the same circumstances would require in order to make a decision about treatment, and that person must be given an opportunity to ask questions and have these questions answered. In providing the information of the person giving or refusing consent, the law requires dentists to provide information about the nature of the treatment, its expected benefits, its material risks, and material side effects, alternative courses of action, and the likely consequences of not having the treatment at all. The college's standard also requires disclosure of the expected fees as part of the consent discussion. Even though this is not a requirement in law, it is important and should be discussed. We all know that determining what the material risks are for a particular treatment can be challenging. However, dentists are not required to disclose every possible risk. Some risks are simply so obvious and remote or insignificant that they don't require discussion with the patient. I'll give you an example. The risk of paresthesia following administration of local anesthetic, for example, is somewhere between 1 in 25,000 and 1 in 800,000. So this risk is so remote that no reasonable person would refuse freezing just to avoid the risk of this complication. In general, the courts have viewed material risks as those that are common and significant, even though not necessarily grave. And those that are but significant, the RCDSO's consent frequently asked questions provide much more guidance on this topic. But generally speaking, the greater or more frequent the risk, the greater the obligation to discuss it beforehand. Excuse me. Now, what does this all mean? This means that there's no ready-made list of information that must be disclosed in all cases. Everything's unique. Dentists must determine what information to share on a case-by-case basis. But the courts have determined that the information that should be communicated is the information that a reasonable person in the same circumstances as the patient would need in order to make a decision. Let me give you an example. If the treatment proposed may affect the patient's ability to enunciate, for example, this information will be much more important for a relevant to a professional singer than others. I had a particular situation in my own practice. I had a professional trumpet player, and every time they came in for a restoration or any treatment, now, doctor, is this going to affect my embouchure? Because otherwise he didn't want it done. And so oftentimes we'd actually give him more time to think about the particular treatment we were going to do and to be sure that we would do our best not to affect that embouchure. Patients must also be given time to consider the options before proceeding, especially in cases where the proposed treatment is extensive, risky, or expensive. We must also be available to answer the patient's questions and be satisfied that the patient understood the information that we've given them and communicated to them. Now, it's helpful to remember that consent does not always have to be explicit or written. Implied consent means that a reasonable person would perceive that a patient has consented. I'll give you an example. When the patient nods their head in response to a treatment proposal or rolls up their sleeve to receive an injection, that's implied consent. I mean, it's obvious, right? Express consent, however, means that the patient has communicated his or her consent verbally and or in writing. In terms of what you might rely on, one over the other, it probably goes without saying that as the potential risks and seriousnesses of the treatment increase, so does the importance of obtaining express consent and documenting, I repeat, documenting that consent conversation fully and carefully in the chart. Now, let's talk a little bit about capacity. The Healthcare Consent Act sets out the requirements that an individual must meet in order to be capable for the purpose of given or withholding consent. Capacity means that they're able to understand the information necessary to make an informed choice about their health care. It is imperative to remember that in Ontario, all individuals are presumed to be capable unless there's a reason to believe otherwise. And it's also important to remember that the test for capacity is not, I repeat, not age dependent. It is a common misconception that there's a minimum age of consent for treatment. In Ontario, there is no age of consent. The capacity must be assessed for minors just like it would be for adults. What does this mean? This means that the consent must be sought directly from a minor, even if that minor is capable, even if there's a parent present in the room. Capacity is also fluid, meaning that it can change with time. It can be present, it can fade, and then return when the patient's mental well-being or clarity of thought return. It's also treatment specific, meaning that a person may be capable with respect to some treatments and not to others, depending on, for example, the complexity of the treatment being considered. Now, when you deem an individual to be incapable, it is always with respect to the treatment being proposed, even if their incapacity is significant in scope. For instance, as a result of age-related cognitive decline, there may be some treatments decisions that are able to be made by themselves. The test for capacity is set out in legislation. The patient must be able to understand the information relative to the decision, and the patient must be able to appreciate the reasonably foreseeable consequences of a decision or lack of a decision. So what happens when we find that a person is incapable with respect to the treatment being proposed? That happens. Consent is still required, but it must be obtained from the patient's substitute decision maker, or SDM. Now, the Healthcare Consent Act sets out a hierarchical list of who can act as an SDM. This includes the individuals described on this slide. The highest ranking person who is available and willing acts as the substitute decision maker, provided that they meet all the necessary criteria. And that includes that they themselves are capable. Make sense? Sorting through SDMs can be thorny, and dentists should approach this with caution. For example, if you obtain consent from the incapable patient's spouse, but there's a power of attorney who is not the spouse, then the consent you've obtained is not valid. It's also helpful to remember that substitute decision makers are subject to their own requirements as set out in law. SDMs are required to give or refuse consent in accordance with the patient's prior capable wishes, if those were known. If they were not known, they must make decisions in the patient's best interest. In the interest of time, we won't be able to get into all the details concerning the specific rules and requirements of applicable to SDMs, but the dentist can seek advice from the Consent and Capacity Board if they have questions or concerns about these decision-making or substitute decision makers. For example, if you think that they're not acting in the best interest of the patient. Let's look at minors for a few minutes. When it comes to minors, dentists should consider factors including their age, maturity, comprehension, and the type of treatment being proposed. For example, whether it's emergent or elective. An important consideration for minors is custodial versus access parents. They rank differently in hierarchy of substitute decision makers within the Healthcare Consent Act. More importantly, courts have the authority to intervene when parents of SDMs are not making decisions in the child's best interest. So let's remember that. It always is in the patient in this case, the child's best interest. Let's talk a little bit about consent forms. Sometimes I think of this as a checklist for pilots before they're going to take off. There's a whole list of checkoffs that they have to make. So consent forms are kind of like that. Some dentists use consent forms. Consent forms have certain benefits. For example, they can help remind the dentist what to discuss and give the patient an opportunity to ask questions. They can also provide evidence of the consent process. However, consent forms can also provide a false sense of security. And that's what we have to keep in mind. As a reminder, consent is a process, not a form. Not all forms are created equal. For example, some forms are just too generic and they don't fit the bill. Forms should be treatment specific and list the services to be performed. So if you're doing surgery, a consent form on endodontics isn't going to cut it. Again, I encourage you to review the frequently asked questions which accompanies the new standard, as it includes some additional advice for creating consent forms. But remember that consent forms are only as good as the consent discussions that accompanies them. It's not just the paper. Excuse me. It's also very important for dentists to document information about the consent discussion. There are no specific legal requirements in this regard, but a concurrent note in the patient's record requiring consent is the best evidence that you've satisfied the requirements for obtaining consent under the Healthcare Consent Act. Having seen cases in ICRC, consent is so many times it comes up. This becomes particularly important if a complaint is made claiming that the dentist did not provide sufficient information or did not obtain valid consent. Both the standard and the frequently asked questions provide much more guidance in this area. Please, I encourage you to review it more than once, because the more you review it, the more familiar you're going to become with it. Documentation is an excerpt from the draft standard. It sets out some recommendations to guide dentists about documentation. This is advice and not a requirement. But believe me, dentists are advised to record details including the date, the patient's name and identity of any other individuals who participated in the consent discussion, the risks and benefits that are discussed with the patient, any significant questions raised by the patient, any alternative treatment options that were discussed, whether treatment was given or refused and by whom, what was consented to, if anything at all, as well as details concerning the expected cost of the treatment recommended. The standard is clear. It's not an exhaustive list, and what dentists document will have to be tailored to the relevant details of each consent discussion. What are some of the pitfalls? As we wrap up, I just wanted to reinforce some key points, including the common areas where dentists will sometimes find themselves getting into trouble. These include assuming you know what is of interest or concern to the patient. It's really critical to ensure that you're engaging in discussion and really listening to what the patient says and wants, so that you understand what's important to them and you can tailor the consent discussion to the patient's sense of priority. Failure to discharge obligations under the Healthcare Consent Act. This one's pretty obvious. It's important that you understand and comply your legal duties to obtain consent. Sometimes the conversation is rushed. This again speaks to the importance of a clear and honest discussion. You owe that to your patient. Consent was not documented. As noted, and we've discussed a few minutes ago, documentation is critical It is a critical part of the consensus process, and it is the best evidence that a dentist can have that a consent discussion took place and that valid consent was obtained. This is especially important in the context of a complaint, hopefully never. And lastly, to confirm that the patient understands what they've been told. As noted, consent is only valid if the patient understands the information and the discussion that was communicated to them. Now, again, the frequently asked questions accompanying the standard provide many helpful strategies to ensure that patients understand the consent process and discussion. What are some of the key messages that we can take away? I want to repeat some key messages now. I trust that by now it's becoming clear that consent is better thought of as a process or a conversation rather than a form or static instruction. It's really part of an ongoing progression which evolves from a dialogue between dentist and patient. It includes questions and answers, a consensual understanding of what is being proposed, and mutually agreed upon to be done or sometimes not done. As you'll have seen, consent can be express or implied. It can be given verbally or in writing, or it can be contrary to clinical advice, as counterintuitive as that may seem. And once again, consent can also be withdrawn. Thank you for tuning in. And as a reminder, I repeat, review the standard, the frequently asked questions, and all other resources on our website. And if you have further questions that are not addressed, reach out to the college's practice advisory service for more advice that can be reached via the contact information on this slide. Thank you very much for your time, and now I turn it over to my colleague, Dr. Deborah Wilson, to share their presentation on the new standard, Prevention of Boundary Violations and Sexual Abuse. Deborah?
Thank you, Anthony. Hello, everyone. I'm Dr. Deborah Wilson, and I'm here today to provide you with a presentation on the new standard, Prevention of Boundary Violations and Sexual Abuse. A boundary violation occurs when the limits of safe and effective professional dentist-patient relationships are crossed. They exploit the power imbalance in the dentist-patient relationship. They place the dentist's personal interest over the best interests of the patient. They can be physical, for example, inappropriately touching a patient, or non-physical, for example, making an inappropriate comment about the patient. They can be intentional or unintentional. For example, they can happen without the dentist intending on crossing a boundary or even while having good intent. It is important for dentists to respect patient boundaries and prevent boundary violations by appropriately managing their conduct. The practice advisory that was previously in effect in relation to this subject has been replaced by the new standard of practice, which has just been approved by Council. This standard was created through a comprehensive process, which included working with working groups, committees, and Council that are composed of dentists and members of the public. There was also a public consultation on an earlier draft of the standard, and feedback was provided by dentists, the public, and a range of experts. The dentist-patient relationship must be based on mutual respect and trust. Boundary violations and sexual abuse, which I will define later in the presentation, violate this. The college has zero tolerance for sexual abuse. Maintaining professional boundaries respects patients, helps ensure the provision of safe and effective care, and upholds the public's trust in dentistry. The new standard sets the requirements for dentists to follow to accomplish this. The standard is supported by 2 companion resources. The links will be placed, the links to 2 companion resources will be put in the chat. The first is case scenarios. This involves cases that demonstrate the standard requirements in practice through hypothetical cases. The second is a frequently asked questions page that contains additional information and guidance in relation to many areas of the standard. Reading these will help you to further your understanding of the standard requirement. This is the table of contents of the standard. This red box is what the new areas are that have not previously been addressed by RCDSO written resources. I will be mostly focusing on discussing these areas during the presentation. Please be aware that there are other requirements in the standard that you should familiarize yourself with. The first new area is in relation to gift giving and receiving. It is common for dentists to receive gifts from patients, and they may also give gifts to patients. There are appropriate gifts to give and receive, such as giving teeth cleaning supplies to patients and receiving a box of chocolates from patients. But there's also inappropriate gifts to give and receive. For example, dentists cannot offer gifts to patients to become or remain patients, and gifts that are overly personal can compromise the boundaries. The new requirement in the standard requires dentists to ensure that appropriate boundaries and clinical judgment can be preserved when receiving and giving gifts. The frequently asked question page has additional considerations. In terms of practical implementation tips, the standard recommends developing an office policy to assist with making decisions in this area. Please see the frequently asked questions page, which provides considerations for what to include in this policy. This policy can also be shared with your patients. A dual relationship means that you have a treating relationship with a patient alongside a secondary relationship, such as being a family member or a friend. When you provide care to someone that you are in a close relationship with, there is a risk that clinical objectivity and judgment can be undermined, and that the patient may not feel free to make their own decisions about their care or disagree with you. The standard does not prohibit dual relationships. However, dentists are required to manage these relationships appropriately. Dentists must maintain clinical judgment and objectivity. Your closeness to the patient should not cloud your judgment. Maintain patient autonomy and decision-making. The patient should feel free to make their own decisions, disagree with you, and get a second opinion. Safeguard patient privacy and confidentiality of personal health information. For example, if you are in a common friend circle, please remember what the patient tells you while receiving dental care is private and confidential and should not be shared with other friends. Practical implementation tips. Ask the person before you agree to treat them if they would be comfortable disagreeing with you or asking for a second opinion. Check in to see if they would feel comfortable sharing sensitive health information with you, as that may have implications for dental care. Refer them to another dentist if you feel their care will be undermined. One dual relationship that is common in dentistry is the dentist-staff relationship. In this case, there is a treating relationship where the staff member is the dentist patient, but there is also a working relationship where the staff member is also a dentist employee. Due to being in a treating and working relationship, which also involves a social component, there is a risk of boundary violations and for the care to be undermined. Practical implementation tips. You can consider entering into an agreement with another dental practice to treat each other's employees. Talk to your staff members about your dual relationship. Explain the boundaries that should be in place, your professional obligations during treatment, and their right to disagree and make decisions regarding their care. Be professional in office and at social settings. This includes at conferences and after work events. Remember that the treating relationship is paramount. The staff member is always a patient first. Refer the staff member patient to another dentist if the clinical objectivity will be affected. In the standard, dentists are advised to avoid entering into personal relationship with persons who are closely associated with patients. Examples of such individuals are the spouse or partner of a friend of a patient, the patient's parent, guardian, or substitute decision maker. In many of these situations, there is a greater degree of vulnerability on the part of the patient, as they may be dependent on someone else to make decisions about their care. A relationship between a dentist and the person closely associated with a patient can also cloud a dentist's own judgment and objectivity regarding the patient's care. The factors on the screen are what dentists should consider in determining whether to enter into a relationship with a person closely associated with a patient. In general, the more complex the care, the higher degree of reliance on the associated person and more of a likelihood of risk to the patient's care. Provision 15 of the new standard requires dentists to assume a patient has experienced trauma and provide care in a manner that is consistent with the principles of trauma and violence-informed care. This means that you do not have to know that a patient has experienced trauma in order to provide care in a manner that is consistent with the principles of trauma and violence-informed care. Here is a definition of trauma and violence-informed care from the standard. Trauma and violence-informed care is an approach to healthcare that recognizes the widespread impact of trauma on patients. Using this approach, dentists treat patients by fully integrating knowledge about victim experiences of trauma and ongoing violence in their practices. The approach facilitates a culture of safety, trust, empowerment, and healing, and seeks to avoid re-traumatization. These are the principles that you have to keep in mind when you're providing care. And just a note that you can find these principles in footnote 23 of the standard. Number 1, understand trauma, violence, and its impacts on people's lives and behavior. If you don't know much about this topic, don't worry. There is a comprehensive resource section in the frequently asked questions page that can help you learn about this. Number 2, create emotionally and physically safe environments for all patients and providers. Remember that a dental appointment can be triggering for those who've experienced trauma and/or violence. For example, many victims of violence have injuries in their facial area, including the mouth, which of course, this is the area dentists will be working on during their treatment. Number 3, fostering opportunities for choice, collaboration, and connection. This really focuses on helping a patient to feel that they have control over their dental appointment and are involved as an active participant in their care. For example, you can tell a patient that they can ask for a break during treatment. Number 4, use a strength-based and capacity-building approach to support patients. Acknowledging a patient's experience of trauma, if they do disclose it, and allowing for meaningful engagement with the patient. For example, taking the time to thoroughly answer any questions they may have can help. You will see that provision 15 in the standard has new requirements that broadly cover physical interactions with patients, including avoiding touching them, using judgment when using touch to comfort them, responding to the patient's behavior, being responsive to their verbal and nonverbal cues, language, and behavior. This can be something as simple as offering to put on the television to put them at ease. The objective is to make them feel as safe and comfortable as possible. Involving patients in their care. As stated earlier, this is about making the patient feel like they have control over the appointment, such as being able to ask for a break if they need one. Permitting patient supports. This can be a support person or a support animal where permitted. Practical implementation tips. Aside from what I've already provided as examples, Please check the frequently asked questions page for many resources on incorporating trauma and violence-informed care in your dental practice. Remember that there are other requirements to prevent boundary violations in the draft standard, including the sections on respecting patient boundaries and appropriately communicating with patients. Here are some of the general tips to implement the parts of the standard relating to preventing boundary violations. Create an office policy with examples of boundary violations. Ensure there is a way for boundary concerns to be brought forward to management or leadership. Provide office training on boundary violations. Sexual abuse has a very specific definition under the Regulated Health Professions Act that is much more than just frank, explicit acts. It includes sexual intercourse or other forms of physical sexual relations between the dentist and the patient, touching of a sexual nature of the patient by the dentist, behavior or remarks of a sexual nature by the dentist towards the patient. This includes flirting, jokes, suggestive comments, or texts. While dentists can treat their spouse has a very specific meaning under the Regulated Health Professions Act. It includes someone they are married to, someone they have been in a common law relationship with for at least 3 years. Dentists cannot treat someone they are engaged to that is not their common law spouse, a boyfriend, girlfriend, or significant other, someone they are in an intimate or sexual relationship for less than 3 years. The only exception to this is if there is an emergency circumstance or the care provided is minor in nature and there is no ability to transfer care to another regulated health professional. Patient consent is never a defense. It does not matter if the patient consents to a sexual relationship in these cases. The dentist can still be found guilty of sexual abuse. Dentists have to report to the relevant health regulatory college when they have reasonable grounds to believe that another regulated health professional has sexually abused a patient. This includes another dentist or dental hygienist. This is a legislative requirement. There is also a new legislative requirement in place. The same duty exists now for reporting personal support workers where dentists have reasonable grounds to believe that they have sexually abused a patient they have provided care or services to. The report has to be made to the Health and Supportive Care Providers Oversight Authority. Practical implementation tips. Dentists can create a staff policy about mandatory reporting obligations. They can also make the college learning module on this topic mandatory for all staff in their office. The link to the module is in the chat below. On this slide, you will find contact information for the Practice Advisory Service if you have any questions about requirements in the standard. You will also see a couple of the resources referenced earlier in the presentation. Thank you for listening. Now I will pass you over to Andrea.
Thank you very much to both Deborah and Antony. Those were both really excellent overviews of the standards, and to all of you who've been sharing your questions and actively listening. We really appreciate your time. I hope you've taken away some really good introductory information about both standards. These are both complicated topics, and lots of links that you can delve into further. Just to close out with a few kind of key messages and takeaways about this session. As you know, the session's been approved for 1 point in category 1. Participants are required to attend for 40 minutes to get that point. You don't need to do anything to receive your certificate. We'll go through the records here on Zoom, and staff will be sending out certificates to you within 5 business days. We really value tonight's session and think it's an important first step in learning more about new standards and taking this opportunity to communicate to you the hard work that's been going on and these resources that we've prepared to help support dentists in practice. We've talked a lot in these sessions about incorporating these tips into practice. And we're offering up to 5 CE points in category 2 for your efforts in incorporating the standards into your practice. And after the session, we'll be sending a hyperlink with information on this to you, so you can learn a little bit more. In the chat, I know there's been lots of good resources shared. As Deborah and Antony have mentioned, there's a frequently asked questions document for both standards, case scenarios for boundaries, and a practical consent checklist. So please check those out. I wanted to touch on, at our council meeting just last week, RCDSO Council have approved 2 new documents for public consultation. So I want to just tell you briefly about those. We've got a draft Foundations of Professionalism document. This is a document that's going to replace our Code of Ethics, and it's going to serve as a foundation for all of our standards. So that's out for consultation right now, as is our draft Artificial Intelligence in Dentistry guidance. If you attended our March 4th RCDSO Connect, you will have heard a little bit about this document. It's now out for public consultation, and it's really geared toward helping dentists navigate ethical and responsible use of AI in their practices. Really encourage you to review those documents. Give us your ideas and thoughts for how we can improve the final versions. We're always interested to hear what you think. It was mentioned in the session tonight, but as always, if you have practice-related questions, please remember we've got a resource for you. Our College Practice Advisory Service is a really excellent team, very skilled. We've got many of the staff are practicing dentists who work with us part-time, and then we have some other really skilled non-dentists, including a hygienist, a lawyer, and a call center expert. You can reach them at practiceadvisory@rcdso.org. Please also stay connected with us. We're on a number of social media platforms, LinkedIn, Instagram, and Blue Sky, and you can follow us there to receive our latest news and updates. And lastly, we are going to be sending an evaluation survey about tonight's session. It's really short, but we value your feedback. We want these sessions to work for you and be interesting and valuable. So we'd really appreciate if you take a couple minutes and complete it. If you like, there's a QR code on the screen, and you can do it now if that is convenient for you. And otherwise, we hope you can join us at our next RCDSO Connect session. That's coming up June 4th. Please look out for an RSVP email in early May about that session. And with that, thank you again so much for taking the time to join us, and enjoy the rest of your evening.